Good evening, Peter Goertz. I'm a psychiatrist. Being a psychiatrist definitely is a privilege, but it also can be quite challenging. And patients I've been seeing led me to bring this issue up today, so-called difficult patients and aspects of interacting with so-called difficult patients. A patient out of the blue assaulted a staff member, and as a staff member yourself, you obviously can have some feelings about that. Another patient also assaulted a staff member, and so various patients brought this or led me to bring up this issue today. In the past, a patient I was reminded of in the ER was the kind of patient that can be quite difficult for psychiatrists to interact with. He was a gentleman who came to the emergency room, and I was there with another doctor, another resident psychiatrist in training, seeing the patient, and he wanted to show us his ID card. And he pulled out the ID card from his pocket, and in the same hand, he had a syringe that he was using to inject heroin. And he was also getting a good amount of benefits from federal benefits. So he was getting a big check every month. And the psychiatry resident who was with me got quite upset when he saw that syringe in the patient's hand, and knew that he was probably using the money that he was getting as benefits to buy heroin. Another patient, who is another kind of patient that can be difficult to deal with, was a lady, poor lady. I remember seeing her, and she was a heroin user, a prostitute, had very poor veins, and I remember needing to draw blood from her inguinal vein, so from her groin. And at one point, I was working on a weekend with another psychiatry resident in the emergency room, and she was in the emergency room, had just spoken with the other psychiatrist in an office. Back then, there was no real separation between the patient area and the offices in the emergency room. This was a separate psychiatric emergency room. And then the other psychiatry doctor realized at one point, oh my God, my money's gone. And then it turned out that patient had stolen the money from the doctor and put it in her vagina. And she was also HIV positive, and the other doctor got quite upset. Another example that comes to my mind is a patient was just getting into work, and a patient greeted me, a demented HIV positive patient on a psychiatric ward, greeted me by throwing her feces at me. She didn't hit me, luckily. So these are examples of some potentially difficult situations to deal with in interactions with patients. And we want to try our best to avoid being arrogant and condescending. And that can be sometimes easy to fall into, that type of attitude, especially if we're feeling angry, annoyed by patients. And one example of that attitude is a term that was used when I was in training called Gomer, an acronym, Gomer, standing for Get Out of My Emergency Room. And that was used in general for patients with multiple medical problems, chronic problems, and who had a major social challenge also, maybe not a good place to stay or a good living situation. So quite a condescending term for patients, which we really want to avoid. Other patients that can be challenging for us, for any people, but also for doctors or patients with a diagnosis of borderline personality disorder, with a diagnosis of antisocial personality disorder, people using drugs and who have consequences from drug use, for instance, endocarditis, hepatitis, osteomyelitis, cellulitis. And that can be upsetting for doctors in an emergency room, for instance, because they treat the patient, and that can take quite some time sometimes. They need a long course of antibiotics sometimes, those patients. And then they go out often and use drugs again, inject drugs again with a needle that is not clean, and then they can get another infection. And that can be quite upsetting for some doctors to see them coming back and after all that treatment, doing the same thing again. Other patients can be quite caustic. Manic patients, for instance, they can really push your buttons. They have a sense, they have an intuitive sense of what your buttons are, and they can really push them. Patients can be dirty, have feces on their hand, and that can be another challenge. Do you want to have a patient who obviously urinated in their pants, sit on your chair? That's actually happened to me in my office. So, various kinds of challenges. And from my experiences, my opinion is it's important to be kind in general, but also with these patients, respectful, courteous, but you do want to set boundaries, and you may need to terminate some patients. If they're sitting in your office and cursing at you and being disrespectful, you want to really set that boundary and make sure they adhere to an adequate level of courtesy, or you're not going to be able to treat them. They may not be able to attend your clinic. Countertransference, as I've kind of alluded to, can be quite a challenge. It's obvious that staff can get quite angry if they see another staff member being hit by a patient, and they may have feelings that may lead them to want to harm the patient. So things that can help us as staff members or as psychiatrists specifically to get to an attitude that's accepting and kind when we're interacting with so-called difficult patients. One thing, for instance, is try to remind yourself in a situation where a patient is being quite difficult to cope with, interact with, where the patient's coming from. What is the action of the patient telling you? What is your interpretation of the action? What is the translation of the patient's action? One aspect may be the patient's, by his actions, his or her actions, telling you, I'm feeling disempowered. I'm feeling like I'm alone. I have no one advocating for me. So if you start thinking about that, that can help you to not see the patient as a potential adversary. Try and remind yourself, many of these patients have been through a lot of mistreatment, abuse, physical, sexual, emotional abuse in their lives. They may be psychotic, really not thinking clearly, and they may be confused from a medical reason, not even know what day it is, and be assaultive because they're confused and scared maybe. They may be people with dissociative identity disorder who potentially misread a situation. I remember one of our teachers when I was a resident told me that a patient I think a teenage patient was walking on an adolescent psychiatric ward, and another patient just turned around and punched the patient in the face, I think, for no apparent reason. But I think she was mentioning that the patient who punched the other patient may have been in a dissociated state. So, but that of course doesn't mean that a huge amount of dissociative patients hit people, but various scenarios can potentially lead to violence. So So-called difficult patients definitely can be a challenge, but they also teach us a lot, in my opinion, and also can teach us a lot about ourselves and our own reactions and responses. Thank you.